Our guest today is Dr. Drew Timmermans, a pioneer in regenerative medicine and the co-founder of Regenerative Performance in Gilbert, Arizona. Dr. Drew is on a mission to challenge the status quo of pain management using cutting-edge non-surgical treatments to help people overcome chronic pain and really reclaim their lives. He is all about going deeper than the symptoms to truly solve the problem, and his work is helping athletes and active individuals and really anybody stay in the game, recover stronger, and unlock their full potential. So welcome, Dr. Drew, man. It's good to have you, dude.
Thank you, man. It is good to be here.
I thought I clicked out on you. We'll maybe edit that out in post. Oh, anyway, yeah, sorry, man. Thanks for being here.
Yeah. Good to be here.
In fact, yeah, it's funny. I was just at your clinic 2 days ago. Was that 2 days ago? Or was that yesterday? No, it was 2 days ago.
2 days ago, yep.
Yeah.
I thought you lost your laptop.
And it was super. Yeah, dude, it's been that kind of week. When you like the inside of my backpack, I know we're getting off topic here, but like
10 seconds in and we're already off. Perfect.
This is my case.
Yeah.
This is the inside of my backpack.
Oh yeah, that's camo for sure.
Yeah. So I look it in there. I'm like, I left it there. And then I went back and looked again and it's there. That's why I don't do surgery. So, we left the tool in there. Anyway. So yeah, I mean, I think a lot of people understand, like people have heard of regenerative medicine. People have heard about stem cells and, peptides are kind of having a moment right now, especially BPC 157, like a TB 500, and then obviously is GLP ones, right?
Yeah. Oh, for sure.
Like those are all having a moment. And then PRP kind of more, PRP's been around for 15, 20 years, but it's really people are kind of coming around to the idea of it. And so I think people have an idea of what regenerative medicine is, but like, what would you say regenerative medicine is?
Yeah, so I think at its core, regenerative medicine is just using different injections of various substances to try to stimulate the body to have a healing response, right? So we get injured, we tear a rotator cuff, we roll our ankle, our body has a healing response. It starts with inflammation, then we get proliferation of cells, and then we get remodeling of that tissue. And so regenerative medicine is just capitalizing on that and using different methods to stimulate the body to go through that process without having a whole new injury that it has to recover from. And so instead of having this like dip in tissue damage and stuff and then rebounding to, a baseline, it's like, oh, we have no new injury, but we stimulate a healing response. And so you can add on to your baseline. So various ways that we do that, but that's kind of like the core of regenerative medicine.
And when you say no new injury, you're talking about like surgery, right?
Yeah, surgery, or even, it's just like you didn't just re-injure your ankle to get that healing response.
Yeah.
We just went in and injected some PRP or something like that.
And I think you would probably agree there is a time and a place for surgery. Maybe you wouldn't agree. I don't know. I think sometimes there is a time and a place for surgery, but I think people don't understand that you are causing a whole new series of trauma when you go have a surgery.
Yes.
If you tear your ACL in half and you want to go back and play a sport, and you kind of ACL is kind of important.
Yep.
So you have to go have a surgery. You just created a whole series of other injuries that you need to also try to recover from.
Yep, 100%.
Which again, if surgery is the option, it's an option. But I think that's an interesting idea of like, hey, we got this injury. We can actually really beef up your body's own response to healing and go that way without having to do another injury.
Yeah. And that's what we're trying to do.
That's awesome, man. So what initially then, because you're not making X-Men, but what really drew you to that specialty? Like, was there a personal moment or a mentor? Like, how did you get into this world of regenerative medicine?
Yeah, so it all actually started with my own back injury. So in 2012, I was in a car accident on the highway up in Canada where I'm from. And I was relatively okay. I had to throw that in there, a little
No, I
Canada
know, but
fan.
we would never know that you were from Canada.
Never, never.
Sorry.
And so I was relatively fine after that accident, but at that time I was still competitive in track and field. I was a middle distance sprinter. And so probably about 2 weeks
National
after,
champion, by the way, Canadian national
yeah,
champion, by the way.
appreciate that.
Yeah.
2 weeks later, was in the gym squatting and tweaked my back, right? And it was Paul Quinn's good old 369 protocol. I
Yeah.
don't know if you're, oh, brutal. So it's towards the end of the kind of the third round of those, and I felt a little tweak in my back. Okay, and it was 2 or 3 days, and I was okay and back at everything. So then about 2 weeks later, I'm running repeat 800s. And
Mhm.
on my second last 800, we had 8 of them to do. So this was the seventh.
Which you should never do anyway. I mean, repeat 800.
800 sucks.
800 is a
800 suck.
diabolical distance.
Yeah, I loved the 600. The 600 was like my most, it's an indoor event. So
Yeah.
you don't see it at like outdoor Olympics and stuff, but I loved the 600. But that extra 200 meters is death,
Yeah.
complete death.
Yeah.
Um, but I literally felt my discs herniate. It's the weirdest feeling, but felt them herniate. And the next day just woke up and like severe pain down my leg, severe intense back pain. Ended up getting an MRI a few months later because it's up in Canada. So, they're
Yeah.
not going to do anything right away,
Oh,
right? And I herniated 4.5 and 5.1. So from there, I did physical therapy, rehab. I worked with a European osteopath, a bunch of stuff, and it got me out of the acute stuff, but I was still left with this nagging low back pain that would radiate down towards my foot, and it was just kind of 24/7. It was always there. Worse when I was sitting for long periods and all this stuff. So I end up moving from Canada to Arizona for med school in September of 2013. Still have back pain. And then at some point in 2014, I think it was like March or April or something like that, I went to a sports medicine conference out in Florida. Oh no, this is 2015. Sorry, it was 2015 because it was 2 years later. So I'll go to a sports medicine conference in my second year, and at the conference, and like I had heard of like prolotherapy and PRP. My cousin was an elite gymnast, and so she had PRP injections for an adductor strain that she had from a guy up in Toronto who like was the doc who did PRP on like all the Olympians in Canada. Like he was the guy to go to, right? So I knew of it, but
yeah.
like I just knew of it, right? So at the conference and learning about Prolo and PRP, and so there's a doc there. He's out in Texas. He's a fantastic doc. But during one of the breakout sessions, he was like, "Hey, anybody got like a lingering injury? And we'll ultrasound it and we'll see what we find." And my hand's up there, right? Because
Yeah.
no one can really figure out why I have this pain. So he diagnosed me with exam and ultrasound with a tear in my iliolumbar ligament. So that's one of the ligaments in your low back that connects your spine to your pelvis, and a tear in the lower lat fascia. So your
Really?
thoracolumbar fascia, yeah. And so later that day, he was like, "Hey, tomorrow we're doing some PRP demos. Come find me and we'll do PRP on you for these things." I'm like, "Sweet, yeah, totally." So next day I get PRP at the conference, and
Real quick,
three
this just
months,
goes by. It doesn't
yeah.
have to be your blood.
No, it does have to be your blood. So it's
Oh,
my blood.
so they
Yeah,
pulled your blood,
yeah, pulled my
centrifuged
blood.
it right there.
Yep, did it all right there at the conference.
Okay.
Yep. And so 3 months later, for the first time in 2 years, I was like 100% pain free.
That's
And so it was that moment that I was just like, holy cow, like
yeah.
that process of first figuring out the diagnosis on why I was actually in pain.
Yeah.
And then the PRP injections, I was like, this is exactly what I want to do for the rest of my life and how I want to help people.
So, I mean, should an MRI have picked that up?
Oh, no. MRIs are not great at picking up fascial injuries. So
Okay.
that's one thing that gets missed quite a bit.
Yeah.
As I've gotten further into practice, there actually are quite a bit of fascial injuries that do show up on an MRI,
Yeah.
but radiologists don't talk about it. So
Well,
I pick them up on an MRI, but the radiologist doesn't.
Well, because a lot of the like, I start talking about fascia with people, and there's a certain subset of healthcare professionals that instantly go, "Nah, BS. We're not talking about that.
Yep.
That's not a thing." But that's crazy. That's great. I mean, I've seen it. Like I've now had too many experience with fascia stuff and what I can do with it that makes me go, yeah, there's more to it than just you can't dismiss it.
Yeah, and again, I think you just go back to basic anatomy and physiology. If something has nerve endings in it that transmit pain signals,
Yeah,
that structure can become painful.
for sure.
100%. And there's so many nerve endings in fascia
Yeah.
for pain.
Well, and I was listening to somebody else talk about that whole idea of like why that like we use percussion, right? Like I use like a lacrosse ball, put some heavy percussion on stuff. Is that I think what we call it the piezoelectric effect, where like all the fascia is interconnected. So if we can affect it here, it spreads out and communicates with the rest
Yep.
of it.
Yeah,
So
yeah. Fascia is a big communication network for sure. It just it the the forces don't get transmitted in ways that like people can measure well.
yeah,
And it also like spans long distances. It's complex, complicated. So I mean, we are just scratching the surface when it comes to fascia and how important it is for the biotensegrity model and everything that we do.
yeah. So within that was like when it had personal meaning for you, and when like, hey, this is how I'm going to pursue this. So when did it become? I don't know if it has any deeper meaning than that, but is there a point where you're like, this was important to me, but you realized it had deeper meaning beyond just fixing yourself and for other people?
Oh yeah, in that moment,
Yeah.
like and again, that moment is over a 3 month period, right? Because it's from injection to really being back in the gym 3 months later and being like, holy cow, yeah, I am, I'm back squatting and doing the things that I couldn't do before. And so that 3 month process was just like great for me, but it
Yeah.
was just like, this is how I want to help people.
Yeah. And to that end, is there I know, I mean, you've been doing what you said 10 years now.
Yep.
Is there in that, I mean, sure there's tons, but is there one person in particular that kind of stands out to you as like the success story?
Dude, I have these stories freaking every month at this point. Like, I think the big ones, like I had a lady, let's see, this was probably about almost 6 months ago now, where she's end stage arthritis. She was told she needs a knee replacement. Didn't want to go through a knee replacement just because of, her personal beliefs about what she wanted to do for her health.
Are we thinking about the same person?
No, actually, that's one of them I'm thinking of, but this is another one.
Okay.
Yeah. Yeah, and she had actually, and well, I'm sure we'll get into this discussion later, but she went to one of those seminars on stem cell therapy, and the company was going to come to her kitchen and inject stem cells into her knee joint. And she is a friend of my wife's aunt. And so my wife's aunt found out about this and was like, "Do not do that.
Yeah.
Go talk to my niece's husband and actually get something that's real."
Right.
So she was up in Montana. She came down for treatment, and 3 months later, I mean, she is able to do what she wants to do in life. She doesn't need a knee replacement. Now, her joint's not regenerated,
Yeah.
right? But she doesn't have the pain that forced her to go to the doctors for them to say, you need a knee replacement. And so those things just happen on a regular basis at this point.
Well, yeah. And it's funny because I was like, you were starting to talk, I'm like, this sounds an awfully familiar, Greg, because I'm working with somebody that came from, and I had always known that you had, like, I had always known that you did this and that, like, it was good, it was successful because I've seen a bunch of your patients. But this one was the one where I was like, holy cow. Because I've
Yeah.
seen most everybody that I've kind of interfaced with hasn't been super, super, super like bad. They've been pretty bad.
Yeah.
And maybe that's because I get to them after you've done your thing. But this woman, I was just like, she was like missing 20 degrees of knee flexion and like could only bend to like 115.
And no lateral meniscus.
Yeah, and no lateral meniscus. And now she's able to achieve zero and get to 140 degrees of knee flexion. She's walking around with little to almost no pain. I think she had no pain. She said,
Yep.
yeah, on when we saw her the other day, and yeah, just ready to get back to training and working hard, and she's not particularly young either. Like,
No.
she was going to get a knee replacement, and so like for me, that was the one where I was like, this, you can take somebody like that and turn it around into this. This is legit.
Yeah.
Like
Yeah, it's
I always
amazing.
knew it was legit, but then it was too legit to quit. Like, that's an old person's joke for those.
Yeah.
Um, so anyway, like, so the practice, I mean, you co-founded the practice with your wife.
Yep.
Um, I guess what are some of the core values that you have that have shaped your approach to patient care, to your practice, and how you interface with patients?
Yeah, I think, I think one of the most important things that we have really stuck to that has the biggest impact, and this applies to my side of the practice, which I only do orthopedics and pain, and my wife's side of the practice, where she handles everything else, is we treat the patient that is suffering, and we respect their symptoms. And what I mean by that is there is so much dismissal in the conventional medical world. You've got shoulder pain, and the doc says there's nothing wrong on your MRI, it's all in your head. And it's like you do a physical exam for even a basic one for 8 minutes, and you're like, I know exactly why you're having pain, and here's our solution to it. And then we do that treatment, and their world has changed. And then so on my wife's side, she deals a lot with like chronic infections, complex chronic disease, these situations where, again, the conventional system is just like, yeah, your CBC is good, so there's nothing wrong with you. These symptoms are all in your head. Go see a psychiatrist.
Right.
And it's like, no, there is a reason that these things are happening. Yes, the psychosocial component of the biopsychosocial model is real,
Yeah.
but our experience has shown us that it's not the biological model in some patients and the psychosocial model in other patients. It's the biopsychosocial model,
Sure.
and all three of those pieces play into it to some degree. Some people it's high biological, low psychosocial. Other people it's high psychosocial, but they're still biological. Like, all three of these are always at play. And so it's just listening to the patient and believing the symptoms that they have and trying to figure out why they're having those symptoms to help them, as opposed to just being like, it's all in your head.
Yeah. No, for sure. And I think I've yet to come across somebody who just purely had pain they made up.
100%.
Now,
100%.
when you're distressed, pain becomes exacerbated
Mm-hmm.
and things become a bigger deal. But
Yeah.
oftentimes, were you distressed because you had pain, or were you already, you know what I mean?
Yep.
And so, yeah, no, I think that's great. You have to respect people's pain, because a lot of times, yeah, they do go, hey, yeah, there's nothing on your MRI. Sorry, dude.
Or they don't even do an MRI. There's nothing on your X-ray, so there's no reason for you to have pain.
Yeah.
Come on.
And I tell people all the time, because we get a lot of like, hey, they come in and they think they've been given a death sentence. They're like, I've got herniated discs. There's nothing we can do. And I'm like, yes, so does the whole, I'll never squat again. I'm like, did you go to the bathroom this morning? Squatted.
Yeah.
Like,
sit down on that chair.
yeah, but also like you realize that like the overwhelming majority of the population is walking around with herniated discs or bulging discs, and not everybody's dealing with pain.
Yep.
Like anatomy is, in some cases, anatomy does mean pain, but it also doesn't mean pain, right? Pain is just a request for change.
Yep. Yeah. And it's interesting on that point. I'll make a comment that sometimes I see that pendulum go too far.
Yeah.
Meaning that a doc will say, yeah, you've got herniated discs and you've got back pain, but everybody has herniated discs, so
Sure.
that can't be causing your back pain. It's like, right. No, that's a logical fallacy. Sure. That doesn't track.
Yeah. In this case, they probably are causing your back pain. And somebody else's, they're probably not. But in this case, they are, and we need to address that.
And you know this, The only way you can know that is if you load the tissues,
Yep.
right? You load that disc, however you're going to load it, and if it causes their pain, I mean, you've got your
Risk.
answer as long as you're ruling out other things. If it doesn't, and no
Yeah.
matter what you do to load that disc, it doesn't cause their pain, then that disc herniation is incidental and it don't matter.
Right.
No.
You've got to be able to look at the each thing, each piece of the anatomy, and go, yeah, figure out how to load it, and go, is that it? If that is,
Yep.
then it is.
Yep.
So, no, I think that's absolutely correct, man. Um, and so for you, I mean, obviously, clinical outcomes. You want great clinical outcomes. That is a standard of like, hey, did we do our job or not? But what
Yep.
for you then also within that plays into outside of clinical outcomes? What else plays into giving exceptional care to you?
So we're not a high volume clinic, and we have strategically chosen to be that way because we want to make sure that, and there's also plenty of research out there that shows that patients get better when there's a stronger therapeutic relationship, right? And I don't want to discount that. If
No.
somebody gets an extra 10% improvement from a procedure because we took the time with them and we sat with them and we listened to their story and we actually cared for them as a human, love it. I'm all for that, right? I don't want to discount that. And so we spend a lot of time with patients where, I don't see 10, 15 patients in a day. I see 3 to 5 patients in a day,
Which shocked
and
me.
that's it.
I mean, it surprised me yesterday or a couple days ago when I came to Shadow and hang out, and you were like, "Yeah, we're going to be here at 8:30. We're starting at 8:30. We're done at 5:30." And I think we saw 5 people all day.
Yep.
Yeah, which is phenomenal because it was really there were a couple things that I noticed. Number one, like your intake with like we had there was a new patient,
Yep.
several, two, right?
Yeah.
Yeah, yeah, and each of those were 2 hours,
Yep.
which was like unbelievable to be able to take 2 hours with somebody. And even at the end of 2 hours, what I thought was really cool was, you're sitting there and you go, is there anything else? Like, and it's supposed to be the end of their appointment. And you're just like, and I knew you meant it. Like if they needed something else, you were going to stick it out.
Yep.
And they were like, is there anything else that I can do for you today?
Yep.
And I think so yeah, I mean, you said it, but also I watched you live it. So
Yeah. Yeah.
it's
I
a,
appreciate that.
that's a really cool thing, man. Um, and so with the people that you guys see, what conditions or cases do you most frequently see? Like what's your sort of,
Yeah, so number one for me is the low back. And I think part of that is just because that's what I talk about the most online,
sure.
just because I have personal experience with that. I've never really had knee pain. I've had shoulder pain, I've had neck pain. I've never really had knee pain, but like back has been the number one thing for me over the last 10 years of my own life. And so the low back is the most, and I also love the low back. The low back, there's just something about it that like it clicks for my brain. I am really good at it. I love the procedures for it. We get fantastic outcomes. And so low back is probably number one. Then number two is knees, just because, 98% of the population has knee issues.
Right.
And then cervical spine
Okay.
is third. Yeah.
And so, um, I guess what would be interesting is for you, what are a few early, like, because I think a lot of the times you end up with people after they've sort of ignored something for a while, or they've maybe necessarily kicked the can down the road and then they tried to go see some other people and it progressed to a point where like then you get called in. Um,
Yeah.
what are some of the like? What do you put a couple early warning signs that someone shouldn't ignore? That like maybe should prompt a visit.
Yeah. I mean, I think when really good question. Um, I think the first signs that your pain is starting to affect your day to day,
Yeah,
right? Because we can have some discomfort or something like that, a little stiffness in the morning, but you can still do everything that you want to do.
sure.
Now, arguably, if that persists for several months, probably good to go, get that checked out to get ahead of it. But the first sign that you're like, oh, I'm not going as hard in pickleball as I want to
Yeah,
because this knee is bugging me.
sure.
Or, oh, I've had to stop doing overhead press because the shoulder's not just it's feeling a little wonky when I do it. Like that is when I think people should be like, I need to do something about this now. So that way it's not 3 years down the road and then we're trying to make up for that lost time and that lost movement.
Yeah. No, I agree. I think, yeah, I tell people like people think of injuries as like something that is they broke something or they had this nasty sprain. And I go, no, an injury is when you start affecting your life and you start trying to figure out and make choices about how you're going to do things. Like if you're like, hey, I'm going to sit down to put on my shoes every day now instead of standing up,
Yeah.
right? Like, or I can't do that anymore because of pain. We might need to take a visit.
Yeah. Yeah. And I would say 95% of the patients I see are that latter category. It's not the, oh, I fell and tweaked my ankle,
Yeah,
or, I was hitting a serve in tennis and I felt my shoulder, blow out or something like that. It's like, hey, I had an injury 12 years ago and it's just slowly gotten worse over the last 12 years.
right. Yeah, no, I agree. Um, so we talked at the beginning. We kind of mentioned regenerative medicine, so I had to define it. I mean, I kind of have what I see as some of the misunderstandings, but what do you see, or what do people often misunderstand about regenerative medicine or PRP, stem cells, that kind of stuff?
Ooh, big question. All right. So I'd say first thing is that people just assume that let's say, well, I'll use knee arthritis as an example, right? So you've
Sure.
got knee osteoarthritis, you get an x-ray, doctor says you're bone on bone or whatever.
He's an 80-year-old, you're bone on bone.
Yeah, yes. No cartilage left. And then I show on ultrasound, I'm like, there's your cartilage. You still have some.
Yeah,
Um, but they just assume that they just need an injection inside the joint. Whether it's PRP, stem cell therapy, prolotherapy, doesn't matter. They just assume that like, oh, you just go inside the joint because arthritis is, loss of cartilage.
sure.
Um, and most of the time, that's not the full picture.
I'm going
And
to
I,
be honest. That's what I thought it was when they're like, "Hey, we're doing a PRP injection for arthritis, or we're doing a stem cell injection for arthritis." I was like, "Oh, cool." They just go in and because that's what I'm accustomed to as far as like how most PRP I feel like is done, how most cortisone shot, those kinds of injections, Synvis, that kind of stuff is done.
yeah, and I will say that is probably still the most common way it is done. It's the subpar, suboptimal way in my experience, right? And I think part of it is because you've had a lot of doctors who are transitioning from cortisone and hyaluronic acid over to PRP.
Mm-hmm.
And so they're just taking the old model of, well, we just put it inside the joint, and then they transition it over to PRP and go, well, we're just going to put it inside the joint.
Yeah,
But a lot of the times there are structures outside the joint. So the medial collateral ligament, the infrapatellar branch of the saphenous nerve, your coronary ligaments, which attach your meniscus down onto your tibia, all of those things can be painful. And sometimes that's actually causing more of the pain in knee osteoarthritis than the actual arthritis itself.
yeah,
And so the misconception is you just got to put it inside the joint and that's it. When in reality, you need a good physical exam to determine which structures are contributing to pain, because the success of the treatment is almost 100% dependent on an accurate diagnosis.
yeah,
And a lot of doctors don't talk about that because if a patient fails PRP, the doctor doesn't want to take responsibility for that. They want to blame the patient. Oh, you didn't do your physical therapy. You didn't, you're just a non-responder or
right.
whatever else. When most of the time it's no, you didn't inject into the structure that's actually causing the pain,
Yeah,
right? If you've got rattling going on in your car and the mechanic just goes, oh, yeah, it's probably your alternator, and change out your alternator, but it wasn't your alternator, you're still going to have rattling in the car.
yeah,
And the same thing applies to chronic pain and these types of injections. So that's the big one. Well, that's a big one.
yeah,
I think the biggest one is just the whole misconception around stem cell therapy.
yeah. Tell me about that.
So, where do I start? Okay, so in the United States, the FDA has pretty clear guidelines on the fact that you cannot take cells from another human and inject them into a different human
Okay.
because they determine that to be a drug. Now, I don't agree that it should be labeled as a drug. Okay. I
Okay.
think there needs to be some form of regulation because there is serious risk that can happen if you get bad actors coming in and not doing proper sterility testing, not making sure that there's not contaminants or viruses or other things that can get transmitted from one person to another person, right? The same way that if someone's in the hospital and gets a blood transfusion, there's a regulatory body to make sure that everything is safe as possible. But
We're not
that blood,
harvesting prisoners in some third world country.
right? But that blood is not a drug,
Right.
right? But they want to take the stem cells in a vial and call those drugs, okay? And the landscape there is shifting a little bit, but that's currently where it's at right now. And so there's been a lot of companies who have actually been shut down by the FDA because they are saying we have stem cells in this product and then they're selling it to doctors, but that's in violation with the FDA. Now, the other layer to that is there have been several research studies that have been done on those products. And the last really good one that was done that I'm aware of at least was I think 2019, where they took so there's a university that did this study. So they're not affiliated with any of the products, right? That's very important. There's no bias here. But they looked at all six of the top products that were being sold in the US at that time, and not a single one of them even contained living stem cells at the time that they would have been injected into the patient. So patients are paying for stem cell therapy and they're not even getting living stem cells
Well, yeah, I
in
mean,
those
dead stem
products.
cells don't do anything, right?
Correct. They do not.
Like,
Now, there are still growth factors and a few other components of the extracellular matrix and collagen that are in those. And so patients can still see benefit, but it's way overpriced for what you're actually getting.
yeah,
And so for that, so the FDA is for the most part okay with what are called autologous stem cell therapy. That means it comes from you.
yeah,
So if, on our mutual patient, we took her fat and her bone marrow, which both contain stem cells, and processed those and re-injected those back into her in the same procedure.
yeah.
And that's how we can do stem cell therapy. So that is one of the biggest misconceptions I think out there is people think that they can just go to a doc, get stem cells in a vial, and get that injected. Now that is coming. There are products that are in development and in phase 2 and phase 3 clinical trials that once those get approved, we will then be able to use them. But as of right now, September 2025, that's not the case.
And then tell me, because you were telling you, I thought it was super interesting. You were telling me about what you're able to do, or how you can actually multiply stem cells for people.
Yeah, so there's something called the Federal Right to Try Act, which essentially says that if a patient has a debilitating condition and they have failed some form of conservative care. So an example is a patient has knee osteoarthritis, they've done NSAIDs, so they've done medication management, they've done physical therapy, maybe they've done a cortisone injection or hyaluronic acid, and they're still having symptoms. They can then apply for the Right to Try Act, which allows them to have access to a drug that is in the pipeline. So it's past phase 1 safety trials. So the FDA has said, yes, we approve that this is safe, but we don't know if it's efficacious yet because they're going through phase 2 and phase 3 clinical trials. And so there's a lab in California that we've partnered with where their product has gone through phase 1 clinical trials. So the FDA has given that stamp of approval. And so we can take a patient's fat, we can send it off to the lab, and they can culture expand it. So they can take 100,000 cells and they can turn it into 100 million cells.
Awesome.
And then the patient has the right to request those back under this Federal Right to Try Act, where we can then treat them with their own expanded stem cells as part of this Federal Right to Try in order to help them with whatever debilitating condition that they have.
That's awesome, man. So
Yeah.
when you do stem cell stuff with people, do they generally just need one bout of it, or do people often need more bouts of stem cell therapy?
It's a great question, and it kind of depends on the nature of the injury.
Okay.
So, if somebody has a degenerative condition, over their lifetime, they are probably going to need more than one treatment,
Okay.
right? And so, somebody has end stage knee osteoarthritis, they get a stem cell procedure, they might have really fantastic relief for 3 years, 5 years, sometimes even out 10, 15 years.
Yeah.
But a lot of patients in general, at some point, will probably need another treatment because the degeneration process is still occurring,
Okay.
right? Someone who has, let's say, they're playing pickleball and they tear the rotator cuff and they have pain and they don't want to undergo surgery, or it's not bad enough that they need surgery. They don't want to do steroids because the risk associated with steroids, and we do a stem cell procedure. That's a patient that's more likely to kind of just need one treatment
Okay.
because, again, it is more of like an acute traumatic thing. Now, I will say they're still at risk for re-injury because, as you know, once you've had an injury, that tissue is different.
For sure.
It's never the same. So you're more at risk. And also, what movement mechanics led them to be in that position in the first place,
Yeah.
right? And so as long as we are, and you know this because we refer patients over to you, but we're bullish about physical therapy.
Yeah.
I tell patients that these injections are going to get you out of the pain hole, but what turns this from lasting from 3 years to a lifetime is physical therapy. Hands down, physical therapy.
And I appreciate that because I think what we do is invaluable. But again, we're not the cure all, end all, be all. And it's, I mean, it's really cool to see how well your patients do versus some other patients who maybe didn't get stem cells or PRP or and just
Yeah.
they're just coming straight to us.
Yeah,
So
yeah, it's a different beast.
yeah, yeah, it's a different animal altogether. So what? So I guess my next question would be for you is, how do you decide between stem cells, PRP, or is it always in conjunction together, or do you ever just do some PRP, some stem cell?
Yeah, so every all there's one exception, but almost every single time we do a stem cell procedure, so either with bone marrow or adipose tissue, we add PRP into it.
Okay.
So there's good evidence that shows that a high dose of platelets will actually help to activate those stem cells that are present in either bone marrow or adipose tissue. And so that always gets paired together. The one exception is we've had a Jehovah's Witness patient over the years,
Sure.
and their beliefs is they don't want to use any blood products. So
Oh, is that Jehovah? Okay, yes, that is.
yeah, and so in that case, we just use the fat derived stem cells,
Okay,
and we did not pair it with PRP.
sure.
But when we do PRP, if like the patient's choosing to do PRP, or if we recommend PRP, obviously, we're not going to add stem cells into that because they're just choosing to do PRP. But so the decision. So I'm very research driven when we have that research. Obviously, we don't have a lot of research for a lot of different conditions, and so sometimes we have to extrapolate. And I'm always transparent with my patients on, hey, we have this study that shows us this,
Yeah.
but these things we don't have research for. We can try to pull from this, but I'm being very clear, we don't have a research trial on this. But the one area that I think that I'll mention is so patients with knee osteoarthritis. So there is a research study that was done in France where the surgeon, where he was actually the first doc in the world to do bone marrow stem cell therapy for an orthopedic condition. Okay,
Okay.
he did it for at first it was non-healing fractures, and then it was avascular necrosis of the hip. So he had the idea that when you do a stem cell procedure for knee osteoarthritis, because cartilage heals from the inside out, that healing starts in the bone and works outwards to the cartilage. He did a study where he took a good sized group of patients. He did bone marrow stem cell therapy inside the joint only in
Mhm.
half of them. And in the other half, he just did it in the bone underneath the cartilage. So it's called a subchondral or an intraosseous injection. And then he obviously tracked pain and all that type of stuff. But the biggest thing that he was looking at was, does this actually change the rate of a person getting a knee replacement?
Yeah.
Because if it changes the rate of getting a knee replacement, that's huge.
Right.
Okay. So the study lasted 15 years, which is like, that's unheard of these days,
Yeah.
right? In terms
Track
of how
data
long a
that long.
research study is going to go on. So 15-year study. And the patients who got a intra-articular, so inside the joint only stem cell procedure, 70% of them moved on to a knee replacement within that 15 years.
Yeah, I'm
Okay.
not. I'm not taking those odds to Vegas
Right, right. It's still better than not doing anything,
for sure.
but still 70% of them needed a knee replacement. The patients who had the intraosseous injection, 20% of them needed a knee replacement over 15 years.
Yeah, I'm putting my savings on black.
Yep. So in a situation like that, if a patient comes to me and says, "Doc, what's the best thing I can do to avoid a knee replacement?"
Yeah,
It's that.
100%.
Hands down.
Hands down.
Now, not everybody can afford that, right?
Sure.
So the second decision maker outside of research and clinical experience is finances,
Yeah.
because these things aren't covered by insurance, and so patients have to invest their hard-earned money
Yeah.
into this. And so if a procedure like that is going to cost, let's say, $18,000, and somebody goes, okay, that's not something I can do.
Yeah.
Then we just scale it back. We go, okay, well, the step down from that is this, the step down from that is this. And then we work to figure out what works in their budget.
Yeah.
But some people go, yep, like it's so important to me to do the best thing possible to avoid this knee replacement. And so, yes, I will reallocate my resources to invest in my knee, my health,
Yeah.
and go through that.
For sure. Well, I think it's yeah. That's great, and I appreciate that guy. Figured at some point finances. I mean, same thing with us, right? Like finances always is part of the equation, and
Yep.
you just kind of have to and whether or not and there is truly the situation where people just can't afford it, or there's the situation where it's just not that worth it to them,
Yep.
and
$100%.
that's okay too.
Yeah.
So stem cells. Now I've heard people talk a lot about exosomes.
hmm
Are those? What's the difference between kind of stem cells and or are they the same thing?
No, yeah, so they're different. So um, exosomes are basically a little packet of information that and there's different types of cells in the bodies that will send out exosomes. Exosomes are not unique to stem cells.
Gotcha.
White blood cells send out exosomes. Platelets actually can send out exosomes. Like lots of different cells can send out exosomes, but in the regenerative medicine space, when you talk about exosomes, it's almost always coming from stem cells, although there are some ways that you can get the exosomes from platelets and use that. But basically, there are these little packets of information that the cells will send out to tell other cells how to heal, how to respond. It's one of their kind of communication systems. But exosomes fall into that drug category that we talked about earlier from the FDA.
Mm.
So as of right now, there are no approved exosome products in the US for an orthopedic condition. And so again, companies and clinics that are using that are at risk,
Yep.
right? There's still a lot of places out there who will say, ah, either they don't believe it's a risk
Yeah.
or they just go, I don't care that it's a risk. And
Sure.
to each their own, everyone gets to decide how risky they want to be with their medical license.
Sure.
I've chosen to take the safer path
Sure.
and not risk my license. And so we used to use exosomes quite a bit prior to the FDA saying, hey, these are drugs.
Yeah.
And they worked really well.
Yeah.
I still think it paled in comparison to using a stem cell because, again, the stem cell is fascinating in that the stem cell actually senses the environment that it's in and then decides what exosomes and information to send out.
Interesting.
Whereas the exosomes have been created in a lab,
Yeah.
where they stress the stem cell in a particular way to get it to release that info, but that may not be the best signaling that it needs once it's inside this patient versus that patient.
Sure.
And so that's why I still think, true cellular therapy is going to be better. Now, one area that I am excited for when some of these products get approved and I can use them, is I've had quite a bit of patients that are just medically too frail to undergo a bone marrow aspiration or a mini lipo aspiration to get the fat or the bone marrow. And that would be a great place for me to say, hey, we actually have something that's off the shelf that we can use.
Yeah.
It's probably not as good, but you can't go through a procedure medically anyways. So
Right.
like it's a moot point.
Yeah. Let's go for what we can do.
Yeah.
And then, it was interesting to me. Everybody's heard about PRP. And I mean, I'm in this space somewhat, the orthopedic space, and I had never heard of PPP. And you were like, yeah, we do PPP. And I was like, wait, what is PPP? So, and maybe I'm out of the loop, but it's the first time I'd ever heard of PPP. So explain a little bit about like what that is and why you use it and how you use it.
Yeah. So when we take blood for our PRP processing, right? We take blood, we spin it down in a centrifuge that concentrates the red blood cells to the bottom. We get rid of those. Then the other part of blood is your plasma, right? So blood is basically just is red blood cells and plasma. So then we take that plasma and we spin it again, and that takes all the platelets and it packs them to the bottom. And then we take that little bottom portion. So now we have plasma that is rich in platelets. That's where the name platelet-rich plasma comes from.
Right.
But then we have all this other plasma that does not really have a lot of platelets in it because they've all been packed to the bottom. And so that is platelet poor plasma.
Gotcha.
And so within the plasma, there is still a lot of really great growth factors that are present that can be useful in certain situations. So probably the best use of platelet poor plasma is actually going to be in muscle injuries.
Okay.
So hamstring tendon tear. The patient we saw together the other day had a pec tear. So when you put it inside the muscle, it will actually help recover that muscle better than platelet-rich plasma will. And part of that is the research shows us that platelet-rich plasma can actually stimulate a little bit of scar tissue inside muscles, whereas the platelet-poor plasma doesn't. And so we just get better healing. And so inside muscles is probably the number one area that we're going to use platelet-poor plasma.
And so, I mean, typical muscle injury, you're looking at like 6 to 8 weeks, right, to heal.
Yep.
How much does PPP speed that up?
Quite a bit. So if you look at like return to play in like professional athletes,
Yeah.
some of these athletes with PPP are back in like 14 to 21 days, like
That's
2 to 3 weeks. So again, for the average person, like if someone comes in with a recreational pickleballer comes in and they just strained their hamstring
yeah,
and it's 2 weeks in, I'm going to be like, hey, go to physical therapy.
sure.
Your body 85% of the time is going to take care of this. We don't need to do anything, right? Because there's nothing on the line.
Right.
You've got an NFL lineman where every game he misses
Yeah.
is a huge deal. Like, yeah, you're gonna do something to shave 3 weeks off of their return to play.
Well, I mean, anytime you hear about like a skilled position getting a hamstring strain, that guy's out forever.
Yeah.
So yeah, if you can speed that up with PPP, that's
Yep.
great.
Yeah.
So here's something, I guess. So people listen to this, they've kind of looked at you, kind of looked at your social media because you are also amazing at putting out content. I wish I had that gift. But if they're hesitant or unsure about reaching out, what would you like them to know?
Oh, good question. What do I want them to know? Uh, so here's what I'll say is there are a lot of really great physicians across the country who practice very similar to me, right? But sadly, we are few and far between. We're the 5%. 95% of the stuff out there is rushed appointments. It's barely any physical exam. it's not proper platelet dosing, it's not good technique with injection, or it's palpation guided, so there's no imaging and things like that. So, if someone's looking locally, you
Yeah.
want to make sure you're doing your research. And I have a bunch of videos online on YouTube kind of covering, what you're looking for and that type of stuff. Um, if someone is interested in working with me, I do free discovery calls. So we'll hop on the phone for 15 minutes. We'll kind of see if we're a good fit for each other. I'll walk through how it would work, even if you're out of state or out of country. We have quite a bit of patients who travel to come work with me. And so we've got that dialed in.
Which is rare for a physician to take 15 minutes to jump on the phone and see if you're a fit for his practice.
Yeah,
So,
very rare. But it's so important because I think it just helps. Well, two things. One, it's my vetting to make sure I think I can help this person,
yeah.
right? Because I've had some patients who get on a call and I go, look, this type of condition, like the results are not good even with what we do. So like, go explore this avenue.
Yeah.
Or, I'll have someone who tries to get on my schedule for something I don't even treat, right? And so it's a vetting process for me, but it also helps reassure the patient that, hey, at least this is something that we work with, we can help with, and makes them more comfortable to travel.
Yeah. No, I think it's great. Um, and so if somebody does want to get in touch with your office, what is the best way for someone to get in touch with your office or book a visit? What's the easiest way?
Yeah, so on our website, regenerativeperformance.com, we've got a link there that you can just either call us and chat with my front desk staff, or there's a calendar link to just directly book the 15-minute call.
It's great, man.
Yeah.
And then for a first time patient, what should they expect with an initial appointment with you?
Hmm. Yeah, so most appointments are between an hour and a half to 2 hours. Usually we'll talk in depth for about 30 to 45 minutes, depending on the complexity of the case, because there's a lot of things that I will learn for that's going to guide my physical exam, guide my review of imaging and things like that during that talking portion. Then it's a really hands-on physical exam. It's extremely in depth, because again, if I'm going to put a needle in somebody, I really need to understand which structures are painful. So we'll do that. Then, depending on the region of the body, we may do a diagnostic ultrasound evaluation. So I'm a certified musculoskeletal sonographer, and so we can go ahead and if it's a shoulder, it's a knee, an ankle, whatever, we'll do a diagnostic scan because ultrasound will show us some things that are better than an MRI would.
Yeah.
There's still a lot of situations where an MRI is going to be better than an ultrasound, but a lot of the times both of these things together are crucial. And then from there, we'll just discuss different treatment options and figure out what the right approach is for that patient.
Yeah. No, and it was great. I watched it firsthand. Like it was cool. 2 hours with somebody and you're like, all right, this is the plan. This is what we got. This is how it's going to go.
Yep.
And then you have any kind of final thoughts for somebody silently struggling with like low back pain who isn't sure where to start?
Ooh. I mean, there is, I always got to shout out Kelly Starrett. I mean, the dude, you know him.
I was just there with him.
Yeah, dude's a wizard. He has so much fantastic, like there's so much good stuff out there on YouTube, but there's also so much crap out there on YouTube. And so, if someone is not ready to get their toes in for like something one-on-one with somebody, anything Kelly Surratt posts is fantastic. The McGill method is also fantastic. I'm a huge McGill guy.
Same.
I'm not a purist McGill guy,
Yeah, for
right?
sure.
There's a lot of really great things like almost every single back pain patient is going to be recommended the McGill Big Three.
And
Like it's
and
just
I'll tell you this
crucial.
right now, there's a lot of PTs that talk a lot of crap about the big three that it's outdated. And I'm like, except you know what? It's like Novocaine. Give us some time, it'll work. Like
Yep.
I use it all the time with our low back patients, and it's great.
Yeah, and it's so research driven.
Yeah.
There's been there's no other researcher in the world who has like studied so much exercise with EMGs to actually like have a scientific approach to which core exercises you should do for stabilization. Everyone else, oh no, everyone needs to do this because like I thought of it and it sounds great and it worked for me.
Yeah.
Okay.
Yeah. Well, and even like back to the Kelly Starrett thing, all of his people with low back get breath work, get breathing,
100%.
because it's a really, really great way to start getting some motion in the spine without movement, but
Yeah.
also to help your nervous system, get your diaphragm active, get some of those stabilizing structures active, and teach your nervous system like, hey, it's okay, we can calm down a little bit. And so
Yeah.
just looking for some of those things, you're right, I think are awesome for people.
And I think one of the things I really liked about Kelly is he did a video a while back on the big three and his take on it.
Yeah.
And what the thing he adjusted was, hey, when you're doing them, breathe.
Yeah.
Right. And I
That's
was just like, brilliant.
yeah. 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 It's the cherry on top of an already awesome Sunday.
Yeah.
Well, dude, I know you're busy. I know we, booked an hour for this thing. And so I really appreciate you being here. I learned a ton from, I've been doing my thing a long time, but I love going and learning from other people. So I learned a ton from you. I learned a ton from you every time we talk, man. So I appreciate you being here. And yeah, if anybody who wants to get in touch, make sure that you go check out the website and get in touch. But thank you again, Dr. Timmermans, for being here, man.
Thanks, Dr. Woods. Appreciate it.
So appreciate it, dude. That was awesome.